Good morning. We're running a bit late, so let's begin with the second parallel session, dual diagnosis, dual pathologies, with Jean-Jacques DEGLON. We're going to be with during this. And BLEVINS from the University of Columbia in New York. He's going to talk about the role of psychostimulants in the treatment and co-occurring ADHD and cocaine use disorder. All of those of you who have been working for several years with addictions, we believe that the poor patients on cocaine are worse off than heroin users. They all have a problem, but with heroin we have the possibility to give substitute therapy to help them stop. But with these patients, with cocaine users, we just simply tell them to stop. Some of them we use caffeine, pharmaceutical caffeine, but it's a way of trying to avoid the symptoms of abstinence. And many of us believe that for cocaine, for methamphetamines, for all the psychostimulants, we can give treatments to help them interrupt their use if possible. In Spain, and I think in Europe, it's not allowed to use amphetamines, which are medicines used in ADHD, but we can't use them for cocaine users or patients with amphetamines. But it's something that's going to happen. Now, I will stop and I will pass the floor over to Dr. BLEVINS to talk about psychostimulants in ADHD and cocaine.
Thank you. Good morning. This microphone, everyone can hear me okay? Good.
Not too fast.
Not too fast. Okay. So the objectives of this talk, first I will review some of the epidemiology and co-occurrence of both cocaine use disorder and ADHD, and then talk some about the rationale of treatment of cocaine use disorder with prescription stimulants. I'll review some of the evidence for treatment of comorbid cocaine use disorder and ADHD with prescription stimulants, and I will mention a few other medications that have been used in this just for context to sort of understand where the science is currently. And then I will conclude by discussing some of the practical applications, so how this is really done both in a research clinic and an outpatient psychiatric or addiction clinic. So first, in the United States, cocaine use disorder recently was surpassed by methamphetamine use disorder in terms of its prevalence. So cocaine use disorder has been pretty stable for a number of years, at about 0.5% of the population. And you can see that methamphetamine use disorder has actually tripled in the United States since about 2016. The stimulant use disorder, which would be prescription stimulants like methylphenidate or amphetamines, if you look at the NSDA, the National Survey on Drug Use and Health survey, from the most recent to the prior, it looks like a significant increase in stimulant use disorder. But the issue is that they changed the methodology of how they asked this question. So it's actually not possible to compare from the previous survey to the current. So it's not possible to understand if this has really increased. But the current prevalence as it is stands at 0.5% of the population. So cocaine use disorder has been stable, and yet a big issue in the United States is that cocaine-related overdose deaths have significantly increased. So we see that following fentanyl, which of course is the highest number of overdose deaths in the US. This is now followed by methamphetamine, which has increased sharply since around 2019. And this is followed by cocaine. This can include co-ingestion of substances, but the number of ingestions and deaths involving cocaine have significantly increased as well. And if you look at comparing cocaine alone to cocaine plus methamphetamine, you can see that the number of deaths is significantly driven by fentanyl, whether it's in the cocaine supply or because it is being used simultaneously, so being used with heroin or fentanyl. You see that the cocaine alone overdose deaths have remained fairly stable in the US, though higher than in this time period from 2008 to 2015, where we saw a slight decrease. In addition to seeing cocaine use disorder being stable, but cocaine-related overdose deaths increasing, we see an increase in ADHD diagnoses in the United States among children. So this compares or shows from 1997 to 2017, 2018, that the prevalence has increased from around 6% to around 10% of children being diagnosed with ADHD. There have been studies that have looked at how many people continue to have ADHD symptoms into adulthood, and most studies estimate this at about 50 to 60% of children or adolescents go on to continue to have ADHD symptoms into adulthood. Now, this can look different, and often does, that these patients most often present with problems with attention or concentration and less with hyperactivity and impulsivity, but nonetheless, this can be problematic for patients if this continues and their treatment is not continued. So this results in about 5% of adults in the US with ADHD. If you look at the comorbidity or the co-occurrence of adult ADHD and substance use disorders, if you look at two different perspectives, so among respondents with a substance use disorder, about 11% also had ADHD. And this is compared to about 4% among respondents without a substance use disorder. If you look at this in the other direction, so among respondents with ADHD, about 15% had a substance use disorder, compared to 5% among respondents without ADHD. So this is 3 times as many patients among the respondents with ADHD of also having a substance use disorder. If you look specifically at cocaine, adults in substance use disorder treatment have high rates of ADHD ranging from 8 to 33%. This is generally across substances. With cocaine specifically, in this sample of US adults, about 12% met criteria for childhood ADHD, and the majority of those, so 80%, continued to have ADHD symptoms into adulthood, and this was about 10% of this total sample. There was another study in Spain that actually looked at around the same, so 200 patients with cocaine use disorder who were actively in treatment, and a fourth of those people actually met ADHD criteria. When they compared the different types of ADHD, the majority had combined type ADHD. That was followed by hyperactive impulsive type, and then that was followed by inattentive type. And a systematic review and meta-analysis of studies of patients with ADHD estimates the prevalence of cocaine use at 26%, so 1/4 of patients using cocaine that also have ADHD, and cocaine use disorder at 10%. So understanding that this ADHD and substance use disorders generally are highly comorbid or co-occurring with each other, the question becomes, how do we treat someone with cocaine use disorder and ADHD? So first, why treat anyone with substance use disorder for their ADHD? Well, they have earlier onset of substance use, and this includes cocaine when ADHD is present. They have more frequent and intense cocaine use. They have a reduced likelihood of going into remission. They have higher relapse rates, both in adolescents and adults. If remission from cocaine is achieved, they have a longer time to reach remission. They have more and earlier treatment exposure, yet they do less well in treatment. And they have higher rates of other psychiatric comorbidities, especially conduct and antisocial personality disorder. So what medications do we use to treat ADHD? So our first-line medications are methylphenidate and amphetamine type stimulants. These are, of course, controlled substances. They are inherently addictive on their own. People can develop dependency to these medications. So there certainly are risks that come with prescribing these medications. There are also significant benefits. For both of these types of medications, we have short and long-acting formulations, and both now also have what we call a prodrug, so it has to be ingested in order to be activated. The serdexmethylphenidate is fairly new, at least in the United States, and lisdexamfetamine has been around for some time. Our second-line treatments are non-stimulant medications, atomoxetine, that's been around for some time, and viloxazine, that has fairly recently been approved by the FDA. And then we have our third-line treatments, guanfacine and clonidine, that are primarily used in children with hyperactive impulsive symptoms, bupropion, which is an antidepressant, and then tricyclic antidepressants. And these have pretty mixed results in terms of efficacy, effectiveness for treating ADHD. So what guides our medication choice when we're thinking about the types of medications to prescribe, or particularly the types of stimulants? So one is we know that short-acting stimulants go into the brain more quickly, they leave the brain more quickly, and this can result in more rewarding effects. Now, when short-acting stimulants are taken orally, we see that this uptake into the central nervous system is fairly slow. So it is not as rewarding, say, as if someone were to intravenously inject methylphenidate, which is where you see this one, yeah. If you were to intravenously inject methylphenidate, you see a very rapid uptake into the brain that then pretty quickly tapers off. With oral methylphenidate, much more slowly, and then a slow tapering. Now, if you look at someone who's treated with methylphenidate short-acting for ADHD, they need to take this medication 2 to 3 times per day, so they will see sort of multiple of these up and down throughout the day, with some peaks right in between the doses, peaks and valleys between the doses. This graph on the far right is looking at amphetamine and comparing intranasal use to oral use. And again, we see similar liking of drug if it's used intranasally, goes into the brain much more quickly, and also comes out of the central nervous system much more quickly. So this is the reason why, generally speaking, we would choose long-acting methylphenidate or amphetamines to treat ADHD. One is it's more effective because you have less of those peaks and valleys, but also because it has less abuse liability. Now, the question obviously that comes up is if people are using or misusing cocaine or methamphetamine, what's going to prevent them from misusing their prescription stimulant? That sounds like a no-brainer. But what we actually see if you look at the population is that small proportions of people actually co-use stimulants, at least in the United States. Now, the highest of those is people that use both cocaine and prescription stimulants, but this is only 7.6% of all stimulant users that use both. So what is the diversion risk with prescription stimulants? So a couple of large surveys have been done. The first that I will mention had 10,000 adults, so ages 18 to 49, and about 8% reported lifetime non-medical stimulant use. This was less than pain medications, which was 25%, sedatives and tranquilizers at 16%, and sleep medications at 10%. Methylphenidate was the most likely. The short-acting methylphenidate, or immediate release, was the most likely to be misused, followed by mixed amphetamine salts, short-acting, immediate release. That was followed by the long-acting amphetamine, long-acting methylphenidate, and then lastly that prodrug, lisdexamfetamine. This second study actually was over 200,000 people that were in SUD treatment, and only 1.8% reported prescription stimulant non-medical use. And this was associated with increased methamphetamine and cocaine use and appeared to have been associated with more biopsychosocial problems. 1.6% reported medical use, so they were prescribed a stimulant for ADHD, and this was actually associated with lower illicit stimulant use. So what is the evidence then for psychostimulants for co-occurring ADHD and cocaine use disorder? So first I'm going to talk about these two medications for cocaine use disorder alone, so not with comorbid ADHD. The idea here, as was mentioned, it's somewhat similar to the concept of agonist therapy for opioid dependence, opioid use disorder, but there are a lot of differences. We can't have these medications sitting on receptors for 24/7, 24 hours per day, 7 days per week, in the same way that we can with methadone and buprenorphine. It's not possible to be on a stimulant all the time. Amphetamines do appear to be more efficacious than methylphenidate for cocaine use disorder. And we also see that there are better outcomes with higher dosing of amphetamines for cocaine use disorder. So what this graph is showing here is that for prescription amphetamines, you're seeing a net sort of benefit compared to methylphenidate, where it's about neutral, maybe favoring placebo, and modafinil, which is not an ADHD treatment or not approved for ADHD. We do see some improvement for cocaine use disorder with modafinil. So now I'm going to talk about a trial that was done by one of my mentors at Columbia University. This was a randomized, two-site, placebo-controlled 13-week trial. Participants came into the clinic 3 times per week for visits. They were randomized to either receive up to 80 milligrams of mixed amphetamine salts extended release, 60 milligrams, or placebo. And they could also go to whatever maximum dose if they were in whichever of these categories. So if they were in the 80 milligram category and they could not tolerate more than 60 milligrams due to anxiety, they could stay at the 60 milligram dose. They also received weekly individualized psychotherapy with CBT relapse prevention, targeting both cocaine use and ADHD symptoms. They were given voucher-based incentives for attendance and $10 a week to return their medications. So these are the outcomes that we see for ADHD in this trial. So if you look at, this is the percent of participants who achieved at least a 30% reduction on this ADHD scale. So we see less than half, 40% achieved a 30% reduction on placebo, compared to 75% on the 60 milligram group, compared to 58% in the 80 milligram group. Now, this is interesting because this is not significant between the placebo group and the 80 milligram group, although you see that it was more than half of the people on the 80 milligram group did have a reduction of at least 30%. So looking at this in a different way, the mean change on that score, we do actually see significance both in the 60 and 80 milligram groups in terms of their mean change of their ADHD scores. And then looking at cocaine use outcomes, so this top line is the placebo group, green line is the 60 milligram group, and blue line is the 80 milligram group. And you can see that there's at least earlier on in treatment, an initial drop, and that pretty much remains the same throughout the rest of the trial. This is looking at data treated as missing or data treated as using, and we see significance regardless of how we analyze this data. So our cocaine use outcomes then for our 60 milligram group, 18% achieved remission in the last 3 weeks of treatment, compared to 30% achieving remission on the 80 milligram group. And these were significantly different than the placebo group, in which only 7% achieved remission in the last 3 weeks of the study. This was a secondary analysis looking at the relationship between ADHD improvement and cocaine improvement in this trial. I will not attempt to explain what an autoregressive cross-lagged structural equation model is, but for any statisticians, I wanted to say that this is how this was analyzed. They looked at the first 6 weeks, and essentially what they showed is that people with improvement in ADHD symptoms at week 2 had a significantly higher odds of cocaine abstinence at week 3. So in this graph here, what you see is about a quarter of the people had improvement in ADHD followed by abstinence. And you see that all of these people had improvement in cocaine symptoms. They achieved abstinence. About a third of the entire group had ADHD improvement but did not achieve abstinence. Another secondary analysis that was done of this trial was looking at impulsiveness as a potential moderator of amphetamine treatment response for cocaine. So ADHD, of course, by definition, involves deficits in impulse control, at least 2 of the 3 subtypes. You could have inattentive ADHD, but likely will still have some symptoms of impulse control. So what we looked at was the Barrett Impulsiveness Scale, which is a measure of trait impulsivity. And the reason we looked at this is I had previously done a secondary analysis of a topiramate for cocaine use disorder study, and that demonstrated that people with a higher trait impulsivity were more likely to improve on topiramate. So I wanted to repeat this analysis in this amphetamine treated group, and we saw similarly that people treated with amphetamine were significantly greater, they had a significantly greater likelihood of achieving abstinence if they had higher trait impulsivity. So this is interesting. So trait impulsiveness also appears to moderate cocaine-related response among individuals with ADHD, though in a clinic, I may say that that would be a patient that I might avoid giving a stimulant for comorbid ADHD and cocaine use disorder for concerns about diversion or misuse of the stimulant. I'm not going to talk a lot about other medications, but again, I think it is important to understand for context. There have been studies looking at methamphetamine, and overall it appears to be less effective for treating cocaine use disorder. A couple of trials looking at both cocaine and ADHD comorbidity. One showed improvement in ADHD symptoms, and no improvement, but also no worsening in cocaine use. Another trial that was done by Francis Levin at Columbia with sustained release methylphenidate showed no difference in either ADHD or cocaine use outcomes, but a secondary analysis did show that those who improved their ADHD symptoms on methylphenidate were also more likely to reduce their cocaine use. Atomoxetine is one of the non-stimulant ADHD medications. It is approved for adult ADHD and has an effect size around 0.5. This is significantly lower than amphetamines or methylphenidate, which have a much higher effect size. So it's an appealing alternative to psychostimulants for those with comorbidity because it doesn't have the same addictive potential or issues with diversion. Francis Levin, again, did do a 12-week, this was an open-label trial up to 80 milligrams, and the participants did have improvement in ADHD, but no change in their cocaine use. And then the last medication I'll mention is lisdexamfetamine, and this was a trial looking at it for cocaine use alone, so not comorbid ADHD. Lisdexamfetamine is a prodrug. It requires hydrolysis by red blood cells for conversion to dextroamphetamine, so the pharmacokinetics are not altered if someone were to use it intranasally or by IV. They would have the same response as if they take it orally, so it has less misuse potential. An initial placebo-controlled trial of 70 milligrams per day, which is the maximum that's approved by the FDA, was not significant for cocaine outcomes. Now, an important thing, though, to note is that lisdexamfetamine is about 40 to 50% as potent as dextroamphetamine is. So you actually can't achieve the same dose with lisdexamfetamine as you can with mixed amphetamine salts, the XR formulation. At least unless you go above the FDA recommended maximum. So at Columbia, we did do an open label trial, a small number, 17 participants, and we said, what if we go by this 70 milligrams, 40 to 50% as potent, so let's use twice the dose. So the target dose was 140 milligrams. They took 70 milligrams twice per day. And what we saw is 37.5% of the people, and again, this is an open label trial, were abstinent in the last 3 weeks of study participation. They had a reduced amount spent on cocaine per day by about 60%. The percent of using days was reduced from 25% to 12%. The average dose of lisdexamfetamine that was achieved was 118 milligrams. And there were 4 people that had dose reductions due to some sort of adverse events, like anxiety, problems with sleep, but they were continued in the trial. They were not dropped out of the trial. So like the mixed amphetamine salts extended release, a higher dose may be necessary for treatment of cocaine use disorder alone, and certainly for comorbidity with ADHD. So practical application, how do we do this in a clinic? So first is that there are screening tools that have been validated for substance use disorder populations and cocaine use disorder populations to diagnose ADHD. These are 3 examples. I won't list all of the sensitivity and specificity, but you can see that these scales have been validated. So that can be the first step, is to use a screening tool that has been validated in cocaine use disorder population. The second step is to do a structured interview, of course, for the specific diagnosis. A screening tool does not give a diagnosis, so this is an important next step. And you also want to assess their baseline level of functioning, and these are some of the scales that can be used to do that. It's very important to discuss goals of treatment and how improvement will be determined. So this is, we want improvement in functioning, right? Not simply a reduction in ADHD symptoms. And we may ask that they demonstrate this in some sort of way, whether this is at their school, work, at home, obtaining collateral information from parents, from significant others. We're going to need to use an adequate dose. As we've said, the trials that show higher dosing may be more effective for cocaine use disorder, and it may be higher than the standard dosing. We'll do ongoing assessments of clear functional improvement. We'll be discussing benefits and risks throughout treatment, and especially the risk around cardiovascular issues and like hypertension. And this is especially true if cocaine use persists in addition to the prescription stimulant, because of course then they're getting a much higher dose of stimulant in general, and this can cause cardiovascular issues. You'll want to discuss the role of urine drug testing early on and also understand what its limitations are. So cocaine very consistently shows up, it can clearly be cocaine use if the person tests positive for cocaine. That is not necessarily true of amphetamines, so there are often false positive for amphetamines on urine drug tests. So when we're choosing a medication treatment, if a patient has severe cocaine use disorder or there has been previous misuse or diversion of prescription stimulants, so first we want to consider a higher level of care. Is an outpatient once a month meeting with a psychiatrist unlikely is to be sufficient for this patient? And at the same time, we might consider starting atomoxetine or bupropion for ADHD. And the results for bupropion for ADHD are not great, but it may be worth trying in this particular population. If mild or moderate cocaine use disorder and there's low risk of misuse or diversion, then I think we want to consider a long-acting amphetamine formulation, and having in mind that we may need to achieve a higher dose, that 20 milligrams of mixed amphetamine salts extended release may not be sufficient, and you may want to consider using the prodrug lisdexamfetamine to reduce the likelihood of abuse. The mixed amphetamine salts extended release is usually started at 20 milligrams per day and can be increased by 20 milligrams each week. So for monitoring, of course, ADHD symptoms, patterns of alcohol or drug use, we're going to be looking at those things each time we meet with the patient. And this is someone who we may actually look more to the OUD treatment paradigms where we're meeting with them once a month or once a week rather, or potentially more frequently, and not prescribing a month prescription at a time. They may get 3 or 4 days initially or a 1-week prescription and then come back in for a check-in, urine drug testing, and to talk about their risks and benefits in an ongoing way. Misuse, diversion, and use disorders, though, are inherent risks of prescribing any controlled medications, whether they're stimulants or benzodiazepines. All patients prescribed controlled substances should be assessed at each visit for signs of misuse or addiction. We want to evaluate this in a very matter-of-fact and non-threatening manner, but there certainly are red flags, patients showing up intoxicated, appearing agitated, psychotic, having more panic attacks, palpitations, other health changes, demanding immediate release stimulants, losing pills or pill bottles, running out early, excessive preoccupation with the securing medications, or having multiple prescribers. So if there's not improvement within 3 months after starting treatment, it would likely be necessary then to consider a taper of the medication. The risks are outweighing the benefits at this point, and you can taper the mixed amphetamine salts by about 20 milligrams per week safely, and this is how it's done in the research studies. You'll want to discuss the rationale with the patient, and this is really about their safety, especially if they're continuing to use non-prescription stimulants because of the cardiovascular risk. And then also thinking about alternative medications like atomoxetine or bupropion. So in summary, cocaine use disorder remains prevalent and stable, though cocaine-related overdose deaths are rising in the US, so there's really more urgency for treatment. Untreated ADHD can negatively impact SUD treatment outcomes. Prescription stimulants, especially long-acting amphetamine, have demonstrated efficacy for cocaine use disorder alone and for co-occurring cocaine and ADHD. Prescription stimulants have misuse potential, though a small percentage report co-misuse. And the severity of cocaine use disorder and other factors like their history and your rapport with the patient should inform treatment of co-occurring ADHD. But close monitoring and attention to outcomes is very important if stimulants are prescribed for these comorbid disorders. And that's all I have.
Jean-Jacques.
Oui. Question
Non, non.
Non, pas de question. Alors, non. Voilà. Alors, on va continuer avec notre deuxième orateur qui va parler de la violence chez les patients.
So we're going to continue with our second speaker. And if you used, I can't hear. Can't hear.
First of all, I would like to thank to Jean-Pierre, Anglaise, Cecilia, and all the BRIS team for inviting me for speaking again here in this nice Congress. It's a pleasure, and today I am going to speak about ADHD and violence. That is important, from my point of view, an important topic that, for the clinician point of view, is relevant. This is my conflict of interest. Today I'm not going to speak about drugs. This is my Spanish and European fundings. And I would like to remember that now I am working in Salamanca in the last 5-6 years. That is a very university city. We attend more or less 300,000 people, more or less. And I would like to invite all of you to visit us. We have a lot of culture, a nice place, and very, very nice food. Well, the relevance of the university is very, very important, as I will mention later. Well, and this is my new team, my new research team, because we are more than 200 people in the service, but this is the section on addiction and dual diagnosis and the research. Well, after that, I would like to start with the definition of violence. Violence is a behavior involving physical force intended to harm, damage, or kill someone, something, some animals. However, so unfortunately, we have to deal with violence because humans are associated with violence. Probably, we need a little bit of violence because if we don't have, we will not survive. But coming to the ADHD field, the violence, it could be associated to drug use, the intoxicated. All of you that are in the emergency rooms are suffering, sometimes patients that are intoxicated with different drugs, that they have bad behaviors or aggressive behaviors, the drug dependence, the regular use of different drugs, some mental disorders. It could be under the umbrella of dual diagnosis, personality disorders, antisocial personality disorders, borderline, and as well ADHD. But I would like to remember that some background, some antecedents of the patient could be as well related with the violence. So violence is a multifactorial process that we have to try to study in different ways. As well, I would like to remember that there are a huge relationship between ADHD and substance use disorders. Previously has been mentioned some different papers, including some of our research, and around 20% of the patients that are suffering a substance use disorder are suffering as well in ADHD. Obviously, not all the patients are equal. There are some differences if we look for the main drug of use, thinking that that the majority of the patients are taking different drugs. There are polydrug users, but they used to have the one or two main drugs, and it's not the same if we are thinking about people with cocaine use disorders or patients with alcohol use disorders. Anyway, there are another factors, the personal antecedents, the adverse childhood experience are clearly related to substance use disorders and maybe as well to the violence, the aggressive behaviors. This is a very nice review of the 2020 or 2021 that I recommend you. From the point of view of the psychopathology, as mentioned before, personality disorder, psychotic disorders, primary psychotic disorders or psychotic disorders induced by the drug use are as well related with violence, with aggressivity. I'm not going to speak too much about this topic, but it's as well important, and as mentioned before, ADHD. What we know? Well, there are some research of the previous century, or the beginning of this century, sorry, that they detected that in the patients, or the people who are in prison, more or close than 50%, they have been suffering an ADHD, and around 50% of the people are suffering in the adulthood. So this is well known that there are relationships between ADHD and being in prison and being an offender. As well, when we are speaking about violence, we have not forget the suicide, the violence, the self-violence. So this kind of patients has been as well linked with more or higher risk of suffering suicide or having suicide ideas. Why? Because this condition, the verbal and physical aggression can result from irritability. The destruction of properties can be linked to impulsivity, the cognitive impairment, the problems with the attention, the inattention, etc. So there are a lot of explications that can link the violence and the ADHD. Now I would like to show you some of our preliminary rates of a sample close to 300 patients that are coming to the outpatient clinic. The majority of them are coming for free. They are not compulsive treatment. 95% of more of the patients are coming without any compulsive treatment. And we study 177 patients because they have completed the Europassy. As usual, the majority of the patients were males, 3 males more or less for 1 human. The majority of them the main diagnosis was alcohol use disorders, but there were close to 30% with alcohol plus cocaine use disorder as main diagnosis. It doesn't mean that they are not taking sometimes, for sure, tobacco, a lot of them cannabis, but this is the main diagnosis. And the age was in the medium, around 50 years old. 1 in 4 have any kind of legal problems. It could be traffic penalties, or some of them have been in prison. This proportion was clearly smaller than the other legal problems. The majority of them were not working, only was working around 30% of this population. And if we look for the academical degree, and by the reason, when I start, I explained that Salamanca is a very university city, because here we have a bias, but it's our population. More than 20% have university studies. If we join high school plus university studies, we have more than half of the sample. This is not normal in another cities, in another settings, in another place. But it's the kind of patient that we have in our city, in Salamanca. Probably in the future, we will focus specifically in the university, in the patient with university degree. Well, this is our protocol. We try to study the severity of the addiction, different scales or interviews for ATHS-2023, and we studied anxiety, state, depression, etc. Well, our result, around 30, a little bit less than 30% of the patient pass the barrier of 30 points in the ARS. It means that it could be an ADHD patient. Remember that we are using a screen tool. As well, the worst that it is looking for patients who have been suffering ADHD in the childhood is over 35%. These results are high. Is around as we expecting, thinking in previous research. Well, if we look for the heteroaggressivity, around 30% of the patients have doing this kind of behaviors. There are no difference. There are no gender difference. We are a little bit surprised in this sense. There are clearly difference. Or we detected the influence of the cocaine. So it's not the same alcohol plus cocaine. Cocaine, it seems that is one of the factors for producing violence in this kind of patient, in the ADHD patients. And when we study when we use the autism questionnaire, the state and trails, the ARS and the Barrat, we detected that with the Barrat, the impulsivity, so is one of the main factors for produce violence. So this is the first finding, that we have to look for patients with the high levels of impulsivity. I am thinking in the previous talk that you put as well the focus in this subgroup of patients. So probably we have to study in all the patients the level of impulsivity. It seems that it is important not only for the ADHD, probably for all the aspects related to the treatment. Well, self-aggressivity, the suicide ideation. As you can see, close to 30% of this population have presented in the past any suicide idea. This is a little bit less than we expected compared with other samples that I will show you later, but it means 1 on 3 patients, so that's a high proportion of patients. As well, we didn't find a gender difference. And here we have no detected difference between alcohol and alcohol plus cocaine use disorders. But my feeling, in the last part I will discuss a little bit, is that we need a little more of potence, a little bit more of patients, because if the sample it will be around 200, 250, probably cocaine as well, it could be present as a factor for suffering suicide ideation. Well, when we study with the other tests, with the other questionnaires, here we detected the anxiety levels, the trails and the state of anxiety, as well as they are important. So we can speculate that probably ADHD with high level of anxiety, probably they are self-harm. They are doing self-harm behaviors. So then we have to take care of these patients that clinically we detected that they are or they are suffering or presenting anxiety. And now, this is the dates of the suicide attempts. It was normal. There are less patients that have doing any kind of attempt. Here we don't study in this moment if they use drugs, if they use another precipitation or however another way for to do a suicide attempt. But we didn't find the gender differences. But anyway, again we detected the relevance of the cocaine use disorders in the alcohol use disorders and ADHD patients. As well, the impulsivity appears to be the main factor related with violence, in this case with suicide attempts. So, as I mentioned before, the impulsivity seems that is one of the most important factors in this field. Well, we can say that we failed. In our sample, we didn't find difference using the R's. There are another different relevant factors, the impulsivity, anxiety, the kind of drugs they are using. Cocaine, it seems that was of the most important factors. But this topic, the suicide, we have studied previously with another sample. This is a huge sample, close to 700 patients that we published 6 or 7 years ago. And as you can see, the levels of ADHD is 60.2%. There are differences in the subgroup that they are suffering suicide ideation compared with the suicide attempts. And inside the suicide ideation, the ADHD is relevant. So in this previous research, we proposed that suicide ideation in addicted patients, here the sample, I didn't mention, there are opiate-dependent patients, alcohol-dependent patients, cocaine. However, this is a very open, very naturalistic sample that we was recruiting for years. And in the ideation, the attention deficit hyperactivity disorder is linked to this situation. We didn't find the association with suicide attempts. Anyway, this is an important finding because the ADHD can be or could be detected without a lot of problems by the clinician if they have enough time and they are able to do a quiet interview or repeat the interview. Why we failed? Well, first of all, because the R's have a proportional false positive. We have to take care with this screening tool that is very good because it's short, it's clear, but there are some false positive. Probably we need increasing the number of patients. Probably we have to reevaluate with the corners, with the interview. The problem of the corners, as you can suppose, is that we need between 40, 50, 60 minutes for every patient. So this is not easy. Even if you have the researchers, the patient have to collaborate with the research. And in Spain, it's very atypical, or we don't use too much pay to the patient. So it's the patient, we are linked to the good feelings of the patient that they want to collaborate with us. I mentioned before that there are some false positive, and we studied this topic some years ago. As you can see, with the R's we detected 21% more or less, but with the corners we detected 60%. So there are 5% of the patients that are false positive. Well, this subgroup can explain that sometimes it's we didn't find the association. But there are some strategies for improving the screening, the result of the screening tools. And we can add the words. We didn't use in this case, we did in the next future, but if you add the words to the R's, the results, with the cut-off point 41 and 14, the sensibility and the specificity is really good. So I recommended you that you can use these two tools because they are easy to do. The patient don't need too much time. So, as a conclusion of this presentation, four ideas for take home. First of all, it seems that ADHD are linked to violence. We didn't find, but we will restudy this sample. But there are evidence according to another research. There are different kinds of violence, not only thinking on heteroaggressivity, thinking as well in the self-harm, in the suicide ideas or attempts. The impulsivity is probably one of the main factors, and the cocaine use disorder as well could play a relevant role. And, well, this topic should be re-studied. And as well from a gender perspective. We didn't find too much thing with the gender perspective, but all the clinicians now that there is not exactly the same patient, men and women, they have some difference when we are thinking in the ADHD. The problem is that we have less women, as usual, in the studies in the sample. But this perspective, I think that is relevant. So thank you very much for your attention, and I would like to. Let me a second. I would like to invite all of you to join us to Mallorca, that we will have a track on ADHD and substance use disorders, obviously. Invited means that please, you have to look for the travel, the tickets and the hotel. But we will be very happy if you join us next year, next spring in Mallorca in the Dual Diagnosis World Association Congress and the Spanish Society of Dual Disorders. Thank you very much. Merci beaucoup.
Merci beaucoup pour cette...
Thank you very much for this interesting talk. Time has gone by, but perhaps we could take 2 or 3 minutes if you have any questions that you would like to ask quickly.
Oui, tu voulais poser... Tu as le micro qui arrive.
The question was about modafinil.
Sorry, I'm just a little bit longer. When I could prescribe stimulants to my French patients, Parisian patients, I had only two options, methylphenidate or modafinil. And they could choose, and some of them chose modafinil. And do you have any experience of modafinil in cocaine use disorder?
Yeah, I would say, I mean, personal experience, yes. It is often a medication that I will prescribe myself, and I've had good outcomes with. The research shows that it's pretty effective, not as effective as amphetamines for cocaine. The issue is in this dual diagnosis population, it's not really very helpful for ADHD symptoms. And especially in these patients with comorbidity, where we already see they need a higher dose of amphetamines, it just seems unlikely that it's going to be effective for treating the ADHD and then therefore the cocaine. But in cocaine alone, it is shown to be effective, except in patients that have comorbid alcohol use disorder. That does seem to reduce the effectiveness.
I wish that you have not listed amphetamine here in France, but if you are able or you are living or working close to the border, list amphetamine, it could be a good option for this kind of patients because the risk of misuse, of abuse is very low. The high of this the drug is low because it is a prodrug, really it's not a drug. So it could be another good option for cocaine-dependent patients because always you are suffering a little bit. It's going to misuse the methylphenidate. From my point of view, methylphenidate is for avoiding the immediately release because, at least in Spain, they crash and they snow, and some of the patients are self-injected the methylphenidate immediately release.
Autre question? Non, alors je souhaite un bon appétit et je remercie les excellents orateurs. Merci.